Hello everyone, my name is Manal Zaman and today I will be presenting the comparative analysis of healthcare for New Zealand and the United States. First, we'll be discussing the insurance mechanisms and costs of healthcare in New Zealand and the United States. In New Zealand, approximately 9% of the country's GDP is spent on healthcare, where 78.6% of that is through public funding. 15% of the total health expenditure is paid out of pocket, and the last 5% is with the use of private health insurance. In New Zealand, tax exemptions and subsidies do not exist for private health insurance companies. However, in the United States, they do. Therefore, in New Zealand, most patients pay their own premiums rather than through work. Private health insurance in New Zealand is offered by many organizations consisting of non-profits and for-profit companies. It's used mostly to cover cost-sharing requirements such as elective surgery in private hospitals and private outpatient specialist consultations. Private coverage in New Zealand can also ensure faster access to non-urgent treatments. About 1/3 of the population has some form of private insurance, and it's purchased predominantly by the individuals. In the United States, citizens or businesses can get health insurance from private insurance companies such as Blue Shield, Kaiser Permanente, while individuals may also qualify for public government subsidized health insurances such as Medicaid, Medicare, and Veterans Affairs. In the United States, we have taken a closer step to universal health care with the use of the Affordable Care Act. However, most of the country is still against universal health care in the United States. Therefore, we have a long way to go. Regarding the provisions in terms of who owns the hospitals and clinics and who the doctors work for, in New Zealand, currently there are 20 district health boards that are publicly elected to their own demographic region, and these DHBs are funded by the New Zealand Ministry of Health. The DHBs follow the Ministry of Health directives. This ensures homogeneity of services throughout the country. The population in each of these regions varies from 33,190 to up to 600,000 people. And then with regions consisting of rural populations, tourists, refugees, or populations with high unmet needs, they receive additional funding to meet the health equity in those regions. In general, the funding to each DHB is calculated using a needs-adjusted population-based formula, and the services covered by the DHBs include hospital care, primary care, geriatrics services, mental health, public health, and community-based intervention services. The general practices, those are partially funded by the government, and the other partial half is funded through private insurances owned by the patients. In the United States, the hospitals, majority of them are business or privately owned, where some are also owned by the state or local government entities. The private hospitals can either be nonprofit or for-profit hospitals, and the doctors work for, depending on which hospital they're working in, depends on who they're working for. For instance, if they're working for a state or local, like county hospital, then they'll be working for the county. If they're working for a private hospital, then they'll be working directly for that private hospital. In New Zealand, regarding who the doctors work for, there was a strong opposition by medical professionals for government funding of general practice services. However, there was a compromise that was reached where medical professionals charged patients with co-payments after the government subsidized the initial service fees. This allowed for, again, fully taxed, funded public hospitals and partially funded but privately owned general practices. Therefore, depending on if the doctors are working in a hospital, they'll be working for the New Zealand Ministry of Health. And if they're working for a privately owned general practice, then they own that practice and they're working for themselves. The two medical schools in New Zealand, Otago and Auckland, are both public and have limited student intake. This makes the medical school system in New Zealand very competitive. Medical school limits are determined largely by the government, which is the primary funder of medical education. Practicing physicians must be registered with the Medical Council of New Zealand. However, there is no limit to the number of registered physicians. Students do pay a portion of costs, presently around 15,000 New Zealand dollars, which is equivalent to 10,100 US dollars per year for a 6-year medical degree. Students from rural areas are eligible for fee subsidies and reimbursements if they return to practice rurally. In terms of primary care, general practitioners are usually independent and self-employed. About half of a general practitioner's income comes from capitated, government-determined national subsidies paid through the primary health organizations. GPs have an average income of 180,000 to 200,000 New Zealand dollars, which is equivalent to 122,000 to 135,000 US dollars per year. In terms of the hospital, New Zealand has a mix of public and private hospitals, but public hospitals constitute the majority, providing all emergency and intensive care. Public hospitals receive a budget from the DHBs based on a utilization pattern, population needs, projections, and government goals. The budget includes the cost of health professionals and other staff. Within the public hospital, the budget is allocated to various inpatient services. A proportion of the DHB funding for elective surgery is held by the Ministry of Health, and payments are made on delivery of surgery. Following a pay-for-performance type scheme, payments can be withheld if a DHB does not meet elective targets. The medical school system in the United States is comparatively larger than that of New Zealand. The United States has over 100 medical schools across the nation. Although it's still very competitive to get into those medical schools, it is far less competitive than that of New Zealand just because there are more organizations available here. The cost of medical school is mostly the responsibility of the medical students. However, they are eligible for scholarships and most likely would need to take out some student loans in order to complete their education. In terms of reimbursement for services rendered, doctors usually are paid, receive their fees paid through patient insurance if they have it. However, if patients are uninsured, then it is something that they need to pay fully out of pocket. If patients do have insurance and the insurance covers about 80%, which is usually the average insurance coverage in the United States, the patient is responsible for the rest of the 20%, which is paid directly to the physician or her hospital organization that the patient is visiting. Here are a few quality of life indicators in New Zealand. First, the life expectancy is about 80 years. The death rate is 6.9 out of 1,000 people. The birth rate is 12.8 out of 1,000 people, and the mortality rate is less than 0.5%. Here are a few quality of life indicators of the United States. The life expectancy is about 78.54 years, whereas New Zealand was about 80. The birth rate is 1.73 births per woman, and the infant mortality rate is a little over 0.5%. The current threats faced by both New Zealand and the United States are threats to health equity, especially among the minority groups. For example, in New Zealand, the Maori and Pacific peoples and those from lower socioeconomic backgrounds face these health inequities, which causes an increased number of chronic illnesses. These chronic illnesses, in turn, result in greater morbidity rates and lower life expectancy compared to the general population. In the United States, these minority groups include Hispanics, African Americans, and those from lower socioeconomic backgrounds as well. Certain barriers that exist include organizational structure, staff interactions, and practical barriers. For example, the Maori people experience discrimination, racism, and the feelings that their healthcare needs are unmet after doctor's visits. These same experiences are faced by minorities in the United States as well. With staff interactions, it was reported that clinicians were unable to build rapport or communicate efficiently with their minority patients, which results in hesitancy in finding further care. Practical barriers that both minorities face in the United States and in New Zealand include financial costs, transportation issues, and practicalities such as organizing leave and or childcare as obstacles to accessing clinics, attending appointments, and receiving appropriate levels of healthcare. In the United States, cybersecurity is a unique threat that is being faced right now. For example, HIPAA violations and data breaches are increasingly common and large, which result in record-setting fines and settlements. For example, in October 2018, the insurance company Anthem agreed to pay the Office for Civil Rights about $16 million in a record HIPAA settlement after they had one of the largest health data breaches in U.S. history. This is becoming even more problematic for healthcare systems and third-party payers as they become even higher value targets for cyber criminals. While conducting this comparative analysis, it's important to keep a few facts in mind. The population in New Zealand is only 5.5 million, which is lower than other developed countries, and could play a role in the efficiency in its universal healthcare system. For example, the United States, with a much larger population than New Zealand, spends 14% of its gross domestic product on healthcare, however, has one of the most inefficient healthcare systems among the developed countries. The population density in New Zealand is 18 people per kilometer squared, where the urban population has grown tremendously in the past few years. However, the rural population has remained quite steady. Therefore, it may be a bit unfair to compare the two healthcare systems, since the geographical regions and demographic characteristics are so different.